I know, Dr. Malhotra, you've talked to us about heart disease this morning, but do you feel that a diet can help with other chronic diseases as well?
Yeah, just to continue on from what Emily said, I mean, she's absolutely right. In terms of, first of all, most doctors' understanding of nutrition comes from TV and magazines. And that's a fact. There's good studies on that up in Scotland. And you know, who gives that advice? Well, a lot of it comes from industry. So it's not a surprise that doctors really generally don't know much about nutrition. But the conventional advice has been, you know, misleading to some degree. And now we're having to deal with the consequences of that. At the same time, we have ourselves as a medical profession also over-exaggerated the benefit of medications at the same time as underappreciating lifestyle. To put it in context, so statins, there's been a lot of controversy around statins. I've been at the center of that controversy as well. And it's not about that people shouldn't take statins. The question is whether statins are right for you. And if somebody has a heart attack and has established heart disease, the benefits are clear in terms of reducing risk of death and mortality, and they outweigh the harms. That's not to say some people won't get harmed, you know, as a side effect or may suffer side effects. That can happen. But overall, the balance is that if you have a heart attack, if you have heart disease, statins definitely are the best medicine for you. But if we compare statins in the high-risk group, where we know there's benefit, and I'll talk briefly about low-risk groups in a minute, because I'm sure a lot of you are probably curious about recent guidance from NICE to prescribe statins to millions more. But if we just concentrate for a second on the people who have high risk and are put on statins, we know from studies that if you compare the risk of death on people who have had a heart attack who are put on statins versus taking a traditional Mediterranean diet, actually, the Mediterranean diet is almost 3 times as effective at reducing the risk of death than taking a statin. So one of the problems we have is it's not about one as a substitute for another in many cases, but it's about embracing both. And in fact, there's a very good study in the United States not so long ago which emphasizes what we call the illusion of protection. People think they take a statin, their cholesterol's lowered because they're very powerful drugs, and then they can go and eat McDonald's and it's fine. And I've seen that throughout my career. That people think they're on, you know, the cholesterol is the be-all and end-all of a reflection of their diet or what's happening in their bloodstream. Well, in fact, actually, a lot of dietary adverse effects happen independent of cholesterol. So really, that's one thing to say. Very briefly, the other thing is, but what about people at low risk? I'm sure I'm going to answer the question before it's asked, because a lot of people ask me this question. So low risk basically means if you've got a less than 20% risk of cardiovascular disease in the next 10 years. Recent guidance from our respected, independent National Institute of Clinical Excellence has come out with a recommendation to saying essentially that GPs can prescribe statins for people at low risk, which in reality would be another 5 million people in the UK on statins. Now, what is the evidence on that? Well, there is conflicting evidence, but I like to cite a study in the BMJ, which again attracts a lot of attention. And the reason I cite this study, because this is completely independent of industry. We know pharmaceutical studies classically are known to underreport side effects and also potentially exaggerate the benefits. So this is done independently of industry. And what they found is that if you're low risk, it does not reduce your risk of death or serious illness. And I subscribe to that view that I trust that more than what necessarily comes out from industry. So if if you came to me and said, doc, should I be taking a statin at low risk? I would say to you, I would let you make the decision, but give you the right information. That is, it may prevent about 1 in 140, so a 1 in 140 chance of you not having a non-fatal heart attack in 5 to 10 years. But at the same time, you've got a similar risk of developing type 2 diabetes. Now, would you take that statin? How many people here would take a statin on that advice? Well, it's interesting, isn't it? I could have said the same thing to you in a different way. I could say to you, take this statin, it's going to reduce your risk of a heart attack by 20%. Now, this is what we've been doing in medicine for many years when we talk to patients. We use something called relative risk. And that actually is a common way of misleading the public without actually lying. Because if your risk is already very low, reducing it by another 20% doesn't make much difference. So we need to change the way we converse with our patients. And I'm working on this in something else coming up hopefully soon about how doctors themselves need to change the way they converse with patients when it comes to benefit and risks of drugs.